So I'm going to shut my chat box down and crack it on. So welcome everybody to the first in what we hope and envisage to be a series of what we're going to call improvement Zooms under the banner of Project A. If you're not really familiar with Project A is an improvement program in the ambulance services that attempts to turn things on its head a little bit. So instead of it being about a top-down, centrally driven command and control improvement, actually this is all about connecting people together, sharing, learning, bottom-up engagement style of approach. So that's Project A in a nutshell. One of the things that came out of the last few months has been a real willingness to share good work that people are doing, just to get conversations going and see if there's something in it for other people. And therefore we've set up a monthly meeting of Zooms, and we're going to start sharing stuff across ambulance service, and it's open to anybody. Whoever wants to join can join. So that's basically the point of today. This is the first one, so we might have a few hiccups along the way, so bear with us. But any learning that we take from this one, we'll take into the next one in September. So if you can have the next slide, please, Lindsay, thank you. So this is the welcome, you're having that from me. As I said, I'm Ian, I'm from NHS Horizons, and I'm the programme lead for Project A, and I'm joined by my colleague Lindsay, who also helps with Project A and is doing all the technical stuff in the background around this Zoom. Then we'll hand over the bulk of the session to David. David from North East Ambulance is going to talk to us about the NEAS Care system, so that'll be the bulk of the Zoom. And then I'll just give you a little wrap up at the end in terms of some of the sort of 2 or 3 other Zooms that we've got lined up around this series of Zooms. Thank you. Next slide, please, Lindsay. So how to take part in the conversation today. Please, you've already found it, most of you. Please use the chat box, yeah? The chat box is excellent for just getting discussion going between you. If you're an introvert, would you believe it? I'm quite introverted. If you're an introvert, it's a fantastic way of getting your point across, and we can all see it and hear it, and and have a discussion about it. And what we're also looking to do is, we don't want this to be passive. So what we're going to do is at various points, I think Dave will, oh, Erin's joined. See, Erin's just joined and used the chat box. So at various points, I'm assuming that Dave will stop and ask for clarification or if there's any questions. What we'll do at that point is we'll ask people to unmute themselves. If people have got any questions or they want to, throw in a comment or whatever, then that's the place to do it. Okay. So does that sound all right to everybody? People just want to nod their heads a little bit. I can see most of you. Does that sound all right? Yeah. We envisage about an hour. So although we've put it in till 3:30, we're actually aiming for about an hour, because we generally find that after an hour or so, most people have done enough in terms of staring into a screen. So without further ado, I'm going to stop, be quiet, and hand over to David. David is the improvement manager, the quality improvement manager for North East Ambulance Service, and he's going to talk to us about NEAS Care. So David, I'm going to hand over to you, please.
Yes, good afternoon, Ian. Good afternoon, everybody. I hope you can all hear me. So just very quickly, warm welcome from North East Ambulance Service. My name is Dave Morgan. I'm a paramedic by background, but currently quality improvement manager and part of the design team for Project A with some of my esteemed colleagues around the country who are on this call today. We've got our evaluation team dialed into this meeting as well, and also a member of the team that was the brains behind building what you are about to see. So very briefly, CARE went live as a pilot in April 2018. And almost immediately, we saw some very interesting results, which we'll share with you towards the end of the presentation. But I think if you can just bear in mind as we go through, what I've personally found and what we found from the evaluation is that we think we've got something which has the ability to not answer the question of our communication problems with a dispersed ambulance service, but definitely a way of improving on what we've got, but also the ability to get the right message out and to influence certain things that we need to get across as a clinical organisation. From the inception, I was one of the clinical managers in the organisation, along with my colleagues on the evaluation. And we struggled to get sort of information at an individual staff level. we were quite good at looking at response times and statistics. But when we wanted to know anything, for example, around the clinical quality of care and interventions around our staff's patient care, it was a difficult struggle to get that information in a timely, accessible format. So we wanted to be able to feed back to our staff and support our managers at the point of care. So in other words, doing it in their area of work. We had a look around and there wasn't a great deal of evidence anywhere. There was definitely no pre-hospital evidence. So we sort of came to a bit of a stumbling block and we realised that actually any gaps that needed to be addressed, we were going to have to do this ourselves. So that's exactly what we did. Can I have the next slide, please, Lindsay? And again, so that's where we've ended up today. A lot of the talk that came from Project A back in June was around feedback, around portfolios, around bundles of care, all of these things that we were already looking at. So I had a bit of an epiphany, which I spoke to Ian about 6 to 9 months ago, that actually we could probably start to answer some of these improvements that have come from staff. So this is what's brought us to today. Can we have the next slide, please, Lindsay? So 2016, if you click through again, that'll take us to what care looked like in 2016, which isn't a rabbit. It's that was supposed to be based on the North East Ambulance Services badge on the shirt. And it was the areas that we wanted to look at: portfolio, medicines management, activities, training, bundles of care, all of these elements which we understand builds up the profile of patient care, but also staff welfare as well. If we can click on that Mickey Mouse, Lindsay, it should take us through to a little video. Let's hope this volume works. Have you got any volume, Ian? I think you're on mute.
Is that working?
The ambulance service collects data about every patient contact to improve the service we provide. Excellence in the North East Ambulance Service is highly prevalent, but until now, we have no formal system to capture it. Intelligence is not the ability to store information, but the ability to know where to find it. Albert Einstein. At North East Ambulance Service, we have access to a wealth of data collected through different systems. This data is collected into one area and then stored in the Trust's bespoke system. The North East Ambulance Service has developed Care, where all staff can view information in near real time through a mobile application. Care is able to capture and recognise excellence in our Trust. Care is the online footprint of an employee's patient's care, treatment, skills and development. It enables staff and their clinical managers to discuss any support required in their role, including the ability to do this when working in different locations. North East Ambulance Service wanted to proactively address any gaps in clinical knowledge, identify training needs due to the ever-changing demographic of patient requirements, and aim to reduce harm and errors over time. Care is positively impacting on patient care by focusing on frontline staff welfare. Care enables feedback at an individual clinician level on a number of key indicators on their own practice. This will support individuals to develop their professional portfolio of revalidation and reflection so that they can see the excellent care they deliver. It will also provide a self-assessment of clinical skills to drive personal development and identify learning needs in order to improve the training offered by the Trust. Care also provides staff with direct links to other North East Ambulance Service dedicated sites. Care is built around two very important pillars: staff welfare and patient safety. These go hand in hand. Care is allowing us to focus on the excellent work we already do, highlight areas for personal development, provide that extra level of support and welfare to staff, put staff and patients at the foremost of everything we try to achieve.
Thanks, Ian.
Safety
Let's go
and
back to the
focused on
slides. Thank you very much. So, in 2014, there was a very sad case of a little girl called Lily Mae Page from the Bristol area, who unfortunately she had a collapse with an undiagnosed heart condition, and unfortunately it wasn't a very good outcome. And when it went to inquest, they were looking at the paramedic training around about sort of this type of skill, that's paediatric work especially. And the long shot was that they actually really decided that the training that they're receiving was inadequate. Now, I think there's a lot that we need to learn from as an organisation and as a whole ambulance service, but we don't really do enough to highlight the areas that provide our patient care and our practice. And if staff have something which they are not maybe as skillful with or as happy with, we have no way currently, up until now, to record that and do something about it. Everything was also paper-based. We were writing out forms to then type them up and then print them off again, and it just all seemed to be going the wrong way around. And the other side is we were great at providing support when we were with a member of staff, but when we weren't with them, how can we provide some level of support to our dispersed staff on a night shift, on a weekend, wherever they may be at that time? So all these questions started to click through, and also for those that are in this presentation or see it later, if you've ever had the call from the HCPC regarding your portfolio, I'm a big believer that we need to look at our own revalidation, the same as the nurses are. I think we need to be a bit more robust in that. Can I have the next slide, please? So what we set out to do is exactly what was written down. We needed to answer the questions regarding patient care, look at forms that we do, could we do any better? What information currently were we collecting through our EPCR that we could actually show to staff, to show them, reaffirm how good a job they're doing, but also look at any areas for improvement. Patient care updates, again with communication and links to other parts of the trust. And improve the quality of the EPCR. So we have issues with the quality of the data you put in is only as good as the quality you can select from, and obviously the outputs from that are then the same. So yeah, so that's what we set out to do, and I think the next slide should probably take us to a bit where we're hoping the technology works. So if I can start sharing my screen. So if we can, if somebody wants to keep an eye out on the participants, and if we can have a thumbs up or a chat box just to say that you can see what it is that I'm seeing. You should have a screen saying NEAS Clinical Annual Record of Excellence, which is CARE. And I hope my dyslexic fingers are allowing me to log in. So we've designed a web-based system that's accessible via any device that can open up and support a web browser. So an iPhone, sorry, there are other types of phones available, but iPhones, iPads, smart tablets, devices, etc., and also available on our own electronic patient record and station desktop. We can't go through everything in total because it would take more than an hour, but generally, if we go back to the original slides, which referred to bundles of care and cycle times and portfolio and learning, we've based the care system around those individual things. Obviously, I'm not clinical at this minute in time, so I'll be asking some of my colleagues to share their screen in a moment. But the main point of it is that we can show the information to our frontline colleagues there and then. Bundles of care, for those that are not familiar with them, or ambulance quality indicators, are a set of evidence-based metrics that will give our patient the best possible outcome. And currently, or previously, it would take around about up to 6 months for the clinical managers to get the feedback to go to staff, which for me was not acceptable. You know, we can't learn anything and we can't do any development for something that happened 6 months historically. It was very difficult to actually to provide the support and the feedback to staff after the time. So what we are looking at now is real-time feedback within, we would probably say, a couple of hours at best. If you close an incident off, that information will probably be able to be viewed within 2 to 3 hours, if not particularly faster than that. So that's the change. That's what we're looking to do. The tiles you see on the left-hand side, if I press them, it opens up different areas for staff to look at, and dependent on what it is that actually you are wanting to do from the system, it will show you what it is that's available for your level. We've made it very interactive. So, for example, you can't see because I've just touched it on my phone, but I've just pressed a time statistics graph, which shows all of the jobs that would have been done by me at that time. Obviously, I'm not operational at this minute in time, so one of my colleagues will show. I think the main part is that we're bringing all the information into one place at one go. So when we mentioned about the HCPC or revalidation or the newly qualified paramedics, we would expect a portfolio to be similar to this. I'm not going to go through all of the details because some of them when I've been testing, but for example, I attended a sepsis event, and the comments there are my reflections of how that affected me and work I'd done with a family member. And that's what we're trying to do. We're trying to build up this portfolio of skills based on the individual, based on the support that we can provide to that individual from their own clinical practice. I'm just going to pause there in case there's any sort of burning questions, or I haven't had a chance to look at the chat box. So if anybody's got any questions, it'll be a very nice time to ask away. Feel free. I'll take that as a no.
I think it's looking really good, Dave. I think it's everybody's in awe of it, to be honest.
Good afternoon, young Erin. How are you?
I'm good, thank you very much. Thank you for the young as well.
Good.
It's just, for me, the question is about replication and how easy it is to replicate, but I'm sure you're going to come on to that later, aren't you?
Hopefully we may touch on that if you remind me later on. I think that the beauty, Erin, is we are now probably a year and a bit into actually where we are with care now. So we've made the mistakes, we've done the errors, we've done lots of PDSAs on this, as you'll quite be very impressed with. So as far as replication and sharing, whatever we can help with in any trust to show you what we've done wrong, but also what we found is right. That's what I think will come out of this. So yes, so we're looking to try and do as much as we can so that the next people who want to take it, be that yourselves, you know, you've got a bit of a running start, I think. Any more questions?
So Dave, where's the information pulled from?
So the information is mainly pulled from the electronic patient record. So again, for those who maybe are not aware, every time we go to see a patient, we will start an electronic record, which used to be paper. That then goes into our data warehouse. And the reason we managed to pull this information together is that we've built this data warehouse so that as the NHS, as we all know, it works on multiple systems. We've managed to get this central repository so that every bit from Cleric, from CAD, from Care, all feeds into this one part of the system, and then we can pull out from there whatever it is we want to pull out. That's the the beauty of how we've created it and how we've managed to create it. So that might be something that people need to think about. You know, the EPCR is a limited bit of data, but when you start adding in all of the other parts and the other bolts, that's when it becomes really, really powerful and really interesting.
Have you found an improvement in patient record completion?
We're actually discussing that today as regards to how many people are completing. One thing we did find, I'll just show Tyler, if you bear with me 1 second. Prior to the launch, we had an issue that 40% of our incidents were closed off with either a blank or a null impression. So again, apologies for those clinicians, but an impression would be what we think a differential diagnosis on the patient is. Chest infection is a good example, or a headache. So we found that because we were able to share this information with staff, we saw a very, very quick, this is a very rough breakdown, but this is an example of mine. We saw an increase or an improvement down to 32% very quickly, because we were influencing and showing staff that actually they were missing some information. So we can help them to improve the impressions, which improves the data, which will then help to improve our ability to deliver better care. If we know we have more chest infection patients, or we know we've got more falls patients, we can, you know, do something about it. So we found it's whether or not it's increased completion of EPCR. We found that at the minute it looks like we've got a slight improvement in the quality that's getting captured in the EPCR. I don't know whether that answers that question. I think it probably does. Okay, I'm just going to take you to a couple of things that are on there, and then I'm going to ask one of my colleagues to share, just to show the self-assessment and a few other things. We have links to other areas of the trusts, which is something which previously you'd have to go to multiple sites to find things such as infection control or IT skills, etc. We've just managed to put them in one area. But again, I think the main point, I'm going to pass to my colleague Richard in a second, is the clinical information. So we're going to ask Richard to share his screen in a second. He's going to show you very quickly some bundles of care and some of his jobs which he's done previously. They are IG safe, so there is no names of patients in any of this. This is all quite safe from that perspective. So I'm just going to stop sharing my screen and allow my colleague to share.
Okay, I'll even need to turn yours down. There we go. We're sitting a little bit too close to each other. Right, I can't multitask, so bear with me.
Dave, one of you might have to mute. We're getting quite a lot of feedback.
Done.
Okay, thank
you. Better?
That's much better, thank you.
There we go. Right. So this is my front screen. As you can see, I'm a little bit busier than Dave. So on here, I have my information coming up. So this is from February this year to August this year. The green ones there indicate care bundles where I have dealt with that case. It's been flagged as our system as to being to needing a care bundle completed. Now that one for stroke there, that's got a red on it, which means that I've missed some aspect of the care bundle. So I can hopefully click on there. Thinking about it. Oh, Oh, it doesn't like me. Oh, there we go. Okay, so I've got a 95% compliance rate. So that will bring up all the cases I've dealt with, which are flagged as needing a care bundle to be completed, of which one, so that case on the 29th of June, I've failed the care bundle. So I can go into there and see what that case was. Now I have access to the EPRF system, so I can look at that EPRF in closer detail if there's any sort of issues with it. If it was a member of staff, they could come to me or one of the other clinical care managers, and we would have a look together and go through and do a review of that case for their development. So when I go through, so it goes on there where it says the test result was actually negative. Now, I recognize this case of the fact that the patient, it wasn't actually a fast positive case. It wasn't somebody having a stroke, so the care bundle didn't apply. So I was able to put the information into there, so that as note, I've done that previously, put that in there to then update the system to say that I haven't missed the care bundle. It just wasn't necessary with regards to this case. Do you want to have a look at that Falls one?
Yeah, just
there we go. So I can then have a look back at my other cases I've dealt with recently as well. Or maybe not, because I think I've just closed myself out. There we go. There we go. So here are some of the recent cases I've been to. So I can have a look through those, review them, and then maybe have a look at the ones that I want to highlight. Oh, we've got a question. We've got a question. I'm going to have to answer this, aren't I?
Got a chat.
There we go. There we go.
Do you want me to answer that one?
Yeah, go on.
Hi, Sarah. In answer to the question, currently we are picking up the bundles of care automatically. It's picking it up from a variety of methods, but at the minute, I would say that we are probably in a very safe position, so we're not missing anything at all. If a call comes through with left-sided weakness, for example, and we arrive and it is a urinary tract infection, the system is still wanting us to double check that actually there wasn't any element of a bundle of care either being missed or not being missed. So currently it's electronic. It then goes to the audit team to go through their section. And as I said previously, we're now at a position where the audit team are auditing in near live time. And if I can show, I've got some graphic information at the end of this presentation to show the data on that, if that's okay, Sarah.
Yeah, thank you very much. Awesome. Thanks, Sarah. I mean, I couldn't have answered that question. Well, I probably could have actually, but I just didn't. So my patients here, you can see in, I was sole responding that day. I've got a patient who's got a full no injury. This was just last week. Now here, I can update the notes on here. So I can put some information in just to further expand on what's been done with that patient. So can't type and talk. Again, bear with me. I'll just talk amongst yourselves. Oh dear. So then, now anyone reviewing this note further on, with this case further on, we'll be able to see that note and see that I've expanded on there, all the additional stuff I've done. So it gives them a sort of a larger picture, and I'll see who is putting chats on.
That's Nigel.
Oh, hi Nigel.
Just,
there we go. Right.
So now if you look at the self-assessment, I think.
Self-assessment, righty ho. So I can have a look at my self-assessment as well, just to make sure that so all staff have the ability to do this. And oh, facing the wrong way. much better on the Xbox. Okay, just want to have a look at that one there. So we've got all our staff can do self-assessments with regards to their skills. So I've done one recently, just an example with here. So I've kind of put a couple of things there, select maneuvers and foreign body management. It's been a while since I've done that. So I've put those down as something that I would highlight that maybe I want to revisit. I'm not perfect, I hold my hands up to that. And this gives me a chance to highlight to sort of my management team that there are things that I maybe want to look at further. And that way the trust can then build training courses or put into our sort of annual training. We've got a lot of these coming through as amber. Do we need to look at this? And it just means that we can keep on top of any staff that are having issues or any lacks of confidence with certain procedures. So, otherwise, everything's generally okay. You happy for me to?
I think you're going to stop sharing your screen.
Okay. Bye.
I think you should be back with me. I don't know what screen we can see. I can see a picture of Richard taking the drink. I think there was a question, so it's okay if I answer it, Ian. So, John, I saw a tab for ESR and OLM integration. Are you pulling source data from these systems to report on? I'm going to introduce probably the most intelligent person in North East Ambulance Service, a gentleman called Richard Muggeridge, who has worked tirelessly and very, very diligently on care. Just to answer that in case I make it up and get it wrong, if that's okay, Richard.
Thanks, Dave. We'll talk about overselling the package, but on the detail, John, ESR data is what we pull through full staff information back in care, and we have access to a range of different trusts and other systems, including ESR, to populate the warehouse. We bring everything into care from the warehouse source, except data that's actually captured in care itself. And then when we have acquired additional information, such as the feedback that Richard was showing just now, that then becomes available as a warehouse source in its own right for reporting through our business intelligence and other systems. I hope that answers that point for you. David, thank you.
Okay, I'm going to go back to sharing the screen. Oh, thanks, John. Brilliant. Go back to share. Oh, sorry, we've got another question. What is your compliance rate for EPCR? That's a question we were discussing this morning. We need to do a bit of work on if we get 100 incidents sent out to us, what is our completion rate? We need to factor in RRVs that are asking for conveyance, and does the EPCR completion go against them rather than the transporting crew? So we have that on our list to do, Karen, but yes, it's a very valid question. I can't give you figures on paper because the old paper, we haven't been on paper for probably 5 to 6 years. So that's a piece of work that we are looking at the minute regarding to if we have 100 EPCRs that we should do, how many we had done. But I think that's something we need to look at in the next couple of months. So let's see if I'll go back to sharing the screen. And I just need to log back in. Bear with me. Obviously, for safety, it logs you back out because we don't want people logging in, leaving it there, and somebody else logging in. We are going to touch on a few of the things as we go through, but we are looking at how we make this the most simple to use for staff and also for people who are using the system. At the end of the day, the end user is the person that is going to be using it the most. And we are mindful that there's some work with the evaluation team have been getting feedback from the clinical managers, and that is then designing what care will look like now and also what care may be in the future. We have one section of reporting, which is very interesting, again, from an influence point of view. So I think probably if we can go back to the presentation, please, Ian or Lindsay, whoever, because I think that, by the way, we are, if you want to share your email address in the chat box or use my email that is on the presentation, we'll happily send this presentation out to you guys. Also, I believe Lindsay is recording this, so we'll be sending it out. So if you have anybody that's of interest or wants to view it again, I'm sure it would be good to put you to sleep tonight. Please feel free to put that in the inbox or the chat box. And hi, Nigel, nice to see you. And we can email that out. So, AQIs are bundles of care. There's 4 graphs on there. The stroke care bundle, we, as well as most ambulance trusts, are fairly compliant. As you can see, if you squint, we're round about the sort of 99%ish for stroke bundles. If you look to the right with STEMI, there was quite an issue around the compliance. If you look at the point of April 18, where we then see an increase in the compliance of the STEMI care bundle, that was the point that care was introduced. So I'm sure that Erin and I could talk about this all day, but if that's a point of where a change came in, that has to be something which we can not solely put down to care, because the CCMs were doing some excellent work around that. But there's been a steady increase through June, through July, through August, and this is the last data that went to the national group. Our audit and effectiveness manager has said that, again, since March 2019, the STEMI care bundle has again improved and improved and improved. So I'll touch on it at the very end, but we need to latch onto the work that Diane Ketley from Horizons and has been doing and looking at the spread and sustainability. So as well as the improvement, we need to make sure that actually we're not just sitting on our laurels, and we're constantly looking at, you know, what else can we do, make an improvement, keep that improvement level, revisit it, do our PDSAs and see whether we can make a difference. I'd hopefully love to come back to you guys in probably 6 months' time, and if we look at the bottom left of sepsis and the bottom right of post-ROSC care bundle, we've just started to report on sepsis, and we have yet to do some work on the ROSC care bundle. But if we apply the same principle, that using the feedback system through care and also in a very, very timely manner, that we be a chest infection. And I've just noticed we've had some of our colleagues from acute join us. Again, the way we've set care up doesn't have to be pre-hospital. It could be anything. All we've done is based it on a set of measurements and then provided some information and feedback as to improvement on those measurements. So this could be anything about pre-hospital anaesthesia. It could be to do with taking an ECG in an acute ward in the hospital. It's just information, but it's the way that I believe that we've delivered it to staff is the improvement behind care. I'm just going to stop because I did see a question, and I don't know whether, I think it came from Ian Baines. Hi, Ben. Nice to see you. Are the main causes of the STEMI increase just the use of care visibility, and hence it was pushed? So to answer that, Ian, we pushed the care app at that time, but also the CCMs, which we'll show you in a sec, backed that up with their clinical one-to-ones. So this is the chance where the clinical managers go out with their staff and work with them on an operational shift in their own environment. And the care app and the bundle of care, or the AQI feedback, was also delivered by the CCM. So no, it wasn't care on its own. It's a combination of care, the work that Richard did with the feedback tool, and that one-to-one or face-to-face interaction is the key. So care is part of the solution rather than the standalone. It did it all without any personal involvement. We couldn't do it without the people on the ground that are doing the evaluation right now. We can't take all the credit from care. If we could have the next slide, please. So this is an example of the feedback loop. We've taken the names out. So this is sort of a brief example of the first one saying, can you please make sure that you record the pain scores around about the drug indication? Can you make sure there's a contraindication? So that's the sort of thing that we're feeding back to staff. An answer back from another member of staff has said that obviously there was no pain relief given, but they've given the reason why, and that's the bit that we missed previously. We had the ability to say to somebody 6 months after the event, you didn't give any pain relief, rather than actually you've had a case where it doesn't look as if there was any pain relief given. And using Richard's example, it could be that there wasn't the reason for the bundle of care not being compliant was a perfectly valid reason. So it's starting to learn, and then us collecting and looking at those themes around why these things were not done. And generally there's always a reason. And if the reason was you forgot, or the reason was you've lost your equipment to take a blood sugar reading, well, let's make sure that we can support you and get you the right equipment. And if it's been that you've just forgotten, well, it's one of those things. We've all forgotten them, me included, more than once. We're only human, so there is a human factors element to it. And we've found that one of the auditors actually made a comment to a member of staff very recently, just to congratulate them on the strength and the quality of their EPCR. That was the feedback. That person didn't need to do that, but they felt that was the right thing to do. And as we've said all along, and there'll be a few people who will nod heads on here, being kind and giving some positive feedback goes a lot further than putting a dashboard on a wall and saying, well done. So I think, again, that's that human element that the CCMs bring to care. If we could have the next slide, please. Apologies, I'm just taking a sip of water. One of the things that the CCMs seem to get a lot of work out of this, but we do what they call station walk rounds. Sorry, we just got a question from Mary. Bear with me a second. Is that by clinicians, auditors, or both? One of the differences we have, Mary, is that we have, and I can only say this from what I've been told, is it's clinicians who are doing the feedback to the clinicians. I don't know whether that happens in every organisation, whether it's auditors feeding back. I don't see which. I can't prove that auditors are better than clinicians or vice versa. But our team exist of HCPC paramedics. I hope that answers that one. So the station walk rounds, very, very roughly, if you look from the bottom two graphs from your left to right, you've seen an improvement in the compliance against those. But again, a bit of praise to Richard on my left. With these station walk rounds, we've mapped the individual questions, for example, around the clinical waste bin. We've mapped them to individual key lines of inquiry from the CQC. And that's not to say that we are here to satisfy the CQC. What I'm meaning is that if we are looking to improve our operational ability to deliver safe walk rounds, well, we have to map them against something. And the best thing at the minute would be our internal and external auditors. So we've decided to base it around those key lines of inquiry. Again, this could be anything, around anything, mapped against whatever you want. This could be individual questions mapped against the HCPC standards of proficiency. It's more the way that we're reporting and the ease of the reporting the benefit of care rather than it just being another graph. It's the fact that we're going down to a level where we're able to respond quickly and deliver effective care. And I'm just going to go back to the chat because it might be a similar question. Question about the quality audit response feedback and how was learning shared across the trust. I'm going to come to that one in a second, Mary, if that's okay. We've got some more work around that in a sec. If I haven't answered it though, please remind me at the end. So again, the CCMs do a lot of work, and we have what we call these clinical one-to-ones, or you might hear them referred to as ride-outs. So the questions that we were discussing with staff on the previous quarter were what you see there. So we were looking at the fast positive, and we were encouraging the safe and effective treatment of fast positive patients, and making sure that we limit the time on scene to as low as possible whilst keeping the patient care in mind. Cardiac arrest checklists to make sure that staff were where they were available, downtime, 5-point harness, all sorts. We have, sorry, bear with me 1 minute. We have a question from Ben. I'll come back to that one, Ben, in a sec, if that's okay. If we just go to the next slide, please. You can't really see this again when you get the presentation out through. Previously, the questions came from myself and a very small team. But what we've decided to do, and what we think is the best approach, is to capture this both electronically and report it out electronically. So from that question regarding the fast test patients, we collect the information from the staff on these ride-outs, on the one-to-ones, and then feed that back to the person who's actually asked us to look at it. So this was one of our consultant paramedics. We are now giving them a bit of more reassurance, a bit of governance actually, about if we get the question right first, what question are we trying to achieve? So using the quality improvement model for improvement, what are we trying to achieve is the most important thing. What do we want to achieve? And we think that that's giving us better information to come out. We've got some work undergoing for some thematic analysis, so that it will be able to pull out negative and positive language from these questions. And the team have worked really hard on around about 6,000 lines of data to interpret over the last 2 months, which isn't an easy task. So which isn't an easy task on its own. And we're looking to share that as part of the evaluation. I shall take the next slide if possible. This is a very, very broad thing which combined into a lot of work within the trust, particularly the post handover line, which is the black line of the 3 at the bottom graph. If you look at the questions at the top, the 2nd, the 3rd, the 5th and the 7th, I believe, were all relating to how we could help staff to get to those patients yet to be clinically assessed. And as you can see, there's a very, very slow but definite improvement in the handover. So we were just basically asking staff what issues they were coming across around the handover. And as part of the larger piece of work, again, I can't prove that Care alone did this, but as a part of the whole package of the work the CCMs did, operational management, everybody in the organisation, Care were able to play their part in getting this handover down a little bit from where we were. And we're also continuing to support staff to see whether we can do anything else to get those patients that haven't been clinically assessed rather than waiting for a long time. Can we have the next slide, please? If you remember what I said very initially, we saw some very quick improvements. At the time when we put Care live in April, we saw a virtually immediate increase of, or a decrease of 8% in our clinical impressions. So we improved that by 8%. We saw a jump of 500% in new users to the GR Calc, which is the online clinical guidance. And we saw an increase of 300% in the CCMs carrying out infection prevention control audits. We didn't expect that. We didn't think that would happen. And we were very, very pleased it did happen. And when we sort of sat back and looked at it, it was around about that influence, putting the right information in front of people with the ability to give them that little nudge and reminder to say, oh, don't forget, you know, have a look at your impressions, have a look at your IPC audits. And again, I think it's just a very shining example of the work that everybody's done behind this, that we can work in a bit smarter, working a bit harder, we can get some real positive benefits from the system. And the next slide, please. This is something we worked on with Ian and Lindsay and Diane, and again with the team, is looking at what it is we can do. We need staff to engage, and we need staff to want to use this system. We don't want it to be a tool where you feel as if, you know, you have to sort of go on it to comply. We want staff to feel as if it's a benefit to them. And this is the next stage of the evaluation that's been happening for the last 10 weeks, and very much so, very, very strongly this morning, is looking at what it is that staff actually need. Is it the portfolio? Is it the visibility? Is it better reflection? All of these things. But the rationale at the bottom is we need to improve patient safety and improve staff welfare. We have to do those two things if we want to look at the demand that's going on across the trust, across the nationwide. We need to improve those two things. We have to. And if the only output from care is that we improve staff welfare and that improves patient safety, well, we've done exactly what we set out to do. If the add-ons of compliance with bundles of care improve because of it, and impressions improve, and EPCR completion rates improve, amazing. That for me is just a bonus on the background of staff welfare is the key to this. Can we have the last bit, I believe? Any questions up to that point? Okay. So the bit we need to do in the future, we've got to learn from what we're doing. We've got to learn around, for example, conveyance is an area we're looking at now. So we're at a level where we can probably safely show staff their conveyance and non-conveyance by their skill level and by the treatment they give and by the clinical impression. But this will help us work both at an individual and a high level, trust level, and CCG level, to work out what possible services are available for, at the end of the day, this is our patient. We've got to look after the public health, and we'll play our part in that. We need to map a bit stronger to our professional registration, and also allow staff to progress if that's what they want to do, to show how they can be better and go for that extra role. But also, as importantly, those staff that are excellent, and we've got lots of them in their roles, CCAs, paramedics, that don't want to progress. Actually, this is that tool to provide them the reassurance that they know that they're doing a great job. And currently we don't have that, so that's something which is coming out very soon. Also, as the Carter report has stated, we need to look at any unwarranted variances and get rid of them where possible. Or if we have them and we're doing as much as we can for them, at least we know that actually we don't need to go down a rabbit hole spending 6 months looking at something which actually we don't or we can't or is beyond our control. Data is the key to that, alongside the feedback to staff. Again, which goes back to this analysis of the clinical one-to-ones, moving into the NQP portfolio. Colleagues and frontline staff have been completing the NQP portfolio without us knowing. They've been using the data from care, which we were over the moon with. And really, it's looking again at, Richard's self-assessment. What does that mean? what do we need to do to support staff rather than waiting for statutory mandatory training to come around every year? Do we need to change the way we do CPD? Do we need to change the way we offer guidance? Could it be that if it's to do with, for example, a traction splint, you generally only get to use it when you're at that road traffic collision? But what about when you need a bit of a refresher or a reminder? How do you get that? So that's what we're starting to change, and we've already started to do that to good effect. And again, the spreading sustainability, thanks to Diane. If you haven't followed her on Twitter, follow her on Twitter. You will learn a lot, and I believe there's a white paper coming out shortly, I think. But some great work from Diane, which has helped me enormously. The last slide, I believe. So I currently would like to think we are at the light bulb level. I'm certainly probably not on this graph. I'm in a different area sometimes, but I think it's safe to say that we've definitely lifted off. So we are the nice person on the left-hand side in the red and white balloon. I look to where the little man or person with their cape is. I want us to be beyond that. But I think with help from colleagues within the ambulance service, within the acute trust, within different areas, I think we can all learn from it. And I'm very much open to comments and feedback after this. And I'll just see if there is any more questions. One for Richard, I think, from Debbie. I shall just look very quickly before we finish off. So Ben, feedback is provided by the governance team. This applies to both positive and constructive. The letter of accommodation approach for good is nice. Okay. Thanks, Ben. I can pick that up with you and send you some information on that. From Debbie, how transferable is the system? Will it be mapped to NEAS systems? I'll probably pass my colleague on to that one in a second. I'll look at Ian's. If you could do one thing differently now you've implemented care, what would it be? What do I think the main transferable benefits are to other services? I think you need to take from it what your organisation needs, and my advice to what your organisation needs is what we've said. Staff welfare and patient care go hand in hand. This tool will allow us to look after patients, which will allow them to look after staff, which will allow them to look after patients. The rest of it is a bonus. It might look slightly differently from what we envisaged care a year and a half ago, 2 years ago, but I don't think it's that far different from our initial wish list of helping staff be the best they can possibly be. Richard's comment I shall leave, but if I just how transferable is the system? Will it be mapped to NEAS systems? How easy would it to be integrated to other trust systems? Richard, can I ask you to maybe answer that one?
Of course. At the moment, it is, as you say, quite mapped to the systems that NEAS uses, but where we have some outside tools in common with other trusts, the degree of transferability will be greater or lesser depending on how much we have in common. It's not a completely white label transferable system yet, but a lot of the elements of it we're looking to make as modular as possible, so that there is a lot of potential there for sharing more than just the ideas behind it, perhaps some of the actual components themselves.
I think that's the last slide. If anyone just want to double check to make sure that there's nothing else. I'm still surprised that we managed to keep 31 participants awake, Ian. I think is probably the best thing to get out of this last hour, because you know me, I can talk for quite a while. So I'm going to be quiet and open it up to yourself, and happy to take any of the questions, and just make sure we've got everybody's email address in the chat box to send this out to. Thank you very much.
Thank you, David, and also exactly on an hour, which is what we said we would try and do. So well done. So thank you for that. As David said, has anybody got any sort of burning questions before I just moves on for the last 5 minutes or so? Anything? Okay, well, thank you, Dave. I think it's really good of you to step forward, tell us about the NEAS Care system, and in fairness, be a bit of a guinea pig around how we might want to run these sessions in the future. So we all massively appreciate you stepping forward and telling us about NEAS Care. Thank you very much. Just for other people's benefits, we have, as I said, got a schedule of improvement talks coming up now. So moving into September, if you're interested, please do get the message out. There will be an improvement Zoom from Anna Parry, who is a programme director within the Association of Ambulance Chief Executives. Anna will be talking about the work that has been undertaken through Project A around wellbeing, and particularly how Schwartz rounds are progressing and the PTSD research work that she's been involved in. I think that would be fantastic to hear and participate in that. Erin also has stepped forward in Yorkshire and will be giving us a talk on the 16th of September about the fellowship, the QI fellowship that's been up and running in Yorkshire and some of the lessons learned from that. So that's going to be a fantastic session, and I'm particularly looking forward to that one. And then we've got one from a gentleman of the Welsh Ambulance Service, Steve Clark, who's going to talk to us a little bit around mental health response developments in Wales. So if you've got colleagues that are interested in mental health response, please do let them know that we've got a Zoom coming up around that on the 23rd of October. And we will be tweeting these out and sharing them through the usual sort of comms methods. Now, before I say goodbye, I want you to do one thing, and that's to write in the chat box and answer me 2 questions, please. One is just a reflection on what you've heard from Dave, and so any reflection you want to make about what you've heard about the NEAS Care system. And the second question is, given that this is the first time we've ever run this, how could we make it even better if? So if you think we need to give more interaction, or we need to give more pauses for conversation, or whatever it might be, if you've got a suggestion for us to improve this, please do so. As I said, first time we've ever done this, so we're looking to develop it as we go. So before I say goodbye, I'm going to hold the silence for a minute and let you go into the chat box and do those 2 questions. A reflection for Dave, even better if, yeah, for us in terms of the Zoom. So can you all do that now for me, please? So Erin's saying, excellent service, providing your staff. I'd be interested to see an evaluation from staff and how the intervention supports them. Sarah says it's just the right length. Thank you, Sarah. A reflection tool for feedback is vital for improving quality in learning. I think that's come from Nigel in Wales. Thank you, Nigel. A great tool, that's come from Andrew, to support frontline clinicians. Thank you, Andrew. It's been a good length. Okay, so an hour, people sort of saying the hour feels about right. Any other, we'll give people another 30 seconds to a minute or so. Keen to look at the integration with acute to inform the patient pathway. Great. Useful introduction to care and the metrics you've included. Length was about right. Thank you, John. Debbie, it looks to be an excellent system. Session again about the right length. Live feedback is needed to capture the learning. This is from Mike. This tool delivers exactly that. Thank you, Mike. Thanks for the information about the tool from Mary. A great presentation. The recording will be very helpful. When we next in touch with you about all right, Northwest can learn. That's fantastic. So there's going to be some Dave, I think you're going to have an approach from Northwest, which would be nice. Okay, so another 10 seconds or so, and then there's one more message just come through. 2 more just come through. Excellent concept, morale boosting, confidence boosting. I realise social media something formal will be excellent. Enjoy the Zoom approach to sharing QI. That was from Yvonne. Thank you. Okay, I think I'm going to leave it there. Now, how we normally end a Zoom is we normally just have a wave at each other. So I'm going to do that traditional wave to everybody. So you ready? On the count of 3, goodbye, everybody. And I hope you make our next improvement Zoom. Thank you very much for joining us. And there's the wave. Bye,
Thank
all.
you. Thank you. Cheers, Ian.
Bye, all.
Thanks, Ian. Thanks, Dave.
Cheers. Thank you.
Thank you.
Cheers, Ben.
Thanks, guys.
Thanks all for attending.